there and Krishna Priya is there. So we'll skip the first case, Dr. I can't find Dr. Vivek. Krishna Priya, if you're there, we can start with your cases.
Hello?
Hi, sir.
Yeah, audible.
Good evening. This is a 9-year-old female who presented to us with 3 weeks of fever and sudden onset right-sided ataxia with slight weakness, slurring of speech and hiccups. She also complained of headache of the right side and also diplopia. On examination, she was becoming a little drowsy over a few hours, and she also had ataxia to the right side, nystagmus, which was bilateral, but more to the right side, and horizontal nystagmus it was, with mild ptosis and enophthalmos of the right eye. Tone was decreased in all limbs, and power was 4/5 in all limbs. Dependent reflexes could not be elicited, and plantar was bilateral flexor. With this complaint, she was admitted and a stroke was suspected, and a 2D echo was done, which showed global LV hypokinesia and myocarditis was suspected. MRI was done. MRI.
Okay, so I have just a video.
This is at presentation.
Yeah.
Showing the horizontal as well as the torsional nystagmus. It was a gate-evoked nystagmus.
Okay. I have just selected images of the MRI. We couldn't get the entire scan. So here we have the diffusion weighted sequences, and you can see there are some focal areas of restricted diffusion, especially in the right temporal lobe, the parietal lobe. These areas which are bright on diffusion, I think these are just normal isotropic diffusion changes which are seen in the on the GWS sequences. On the ADC, these were the ones which are reversing, the ones over here in the subcortical cortical regions, in the temporal and parietal regions. And also there's obvious abnormality in the right half of the medulla and also in the bilateral cerebral hemispheres, more on the right inferior cerebellar hemisphere. Yeah, more detailed sequences. We have additional ADC sequence and phase sequence. You can see there's a reversal. That is, there is an infarct out there in the right medulla and the inferior cerebellar hemisphere, pertaining to the territory of the posterior inferior cerebellar artery and the vertebral arteries. I don't have a MIP angio, but there's a video of the angio. If you can bear with me, the right vertebral artery does not demonstrate any flow in comparison to the left. This was a non-contrast time of flight angio. So if you see from the origin, the right vertebral artery does not demonstrate any flow. Similarly, on the MIP images, the right vertebral artery is not visualized. And also in the neck angio, the entire right vertebral artery is not visualized. MRV was done. MRV demonstrated normal appearance, so stenosis, no thrombosis. Then a contrast veno, CT angio and veno was done. And here you can appreciate there is some visualization of the right contrast uptake of the right vertebral artery, but in the V2 and V3 segments, let's see if I can pull the video back. So vertebral artery is visualized but thinned out, and over here especially there is reduced flow and contrast uptake of the vertebral arteries. So V2 and V3 segments and the proximal V4 segments demonstrate reduced contrast uptake of the right vertebral artery, whereas the contralateral side was demonstrating normal uptake. So the question here was are these related? The posterior circulation is related to vertebral artery dissection, and the supratentorial anomalies can that be explained by myocarditis or a cardiac emboli? Is that right, Krishna?
Yes, sir. There
Okay,
was
so
a
you
doubt
think,
whether, yeah, there is a dissection component when they
okay,
were examining, zooming in.
okay. So dissection, I don't have the sequences, but yeah, it is a possibility, I think, on the angio, the contrast angio, CT angio, but we usually have a fat set T1 MRI, which can see the interluminal hematoma, or a non-contrast CT, which can also sometimes demonstrate an hematoma, indirect marker. But the CT angio can be a possibility, I think. But the question was, is this a dual pathology of a infection-related ischemic changes or cardiac emboli in the supratentorial region? Is that right?
Sir.
Okay, all right. Yeah, I'll open the case for the panelists if they have any additional comments. tying up both the positive circulation and the supratentorial circulation stroke. Yeah, Sridhar has mentioned, yeah, Sridhar, I agree, but yeah, unfortunately, we didn't have a dynamic scan. So we usually do an MR first, then a CT, just to avoid contrast. I think MRI is certainly helpful for rotational angiography. Yeah, the question is what postal circulation stroke, okay, can be explained by the vertebral arteries, but the right temporal and parietal ischemic changes, is it related to secondary to infective small vessel ischemia or cardioembolic stroke, given that the child has myocarditis? Dr. Vivek, para-infectious process and postal circulation stroke?
Right.
Hello.
Yes.
Yeah, good evening.
Please go ahead. Good
Yeah,
evening.
so in this child, actually, because I mean, we are seeing a lot of these cases now during sepsis when they're admitted. The ejection fraction is poor. Probably it's being picked up more now because of the bedside echo being available. So we were thinking, because this is looking more like a shower of emboli and not really limited to the posterior circulation. But
But the emboli,
thrombosis in the vertebral artery,
thrombosis, that would not,
cannot be explained
yeah.
by this. Yeah. So is it like two processes happening together as a para-infectious, as Dr. Vivek Jain has mentioned, or is it everything can be explained by just one etiology?
I don't think the thrombosis can be explained by cardiac embolism if you're thinking of tying up the supra-infratentorial one. Infectious process maybe can tie to both.
Yeah, so probably the para-infectious, the same increased D-dimer and all those things might have led to the thrombosis. And I mean, it's a corollary. We don't know. I mean, D-dimer is high because of thrombosis actually. And probably that cardiac component is also added and which may be contributing to the anterior circulation. So probably both the things are applicable
Or
here.
just an infective process causing the ischemia, Dr. Kavita, especially the supratentorial ones. Child had fever, I think, no? Fever or some degree of
Child had fever for 3 weeks. At admission, child's D-dimer was 14,000.
Okay.
So is anybody else like looking at the bedside echoes when the child is admitted with any kind of severe infection? Because I think a lot of these unexplained strokes, we are finding that probably they are cardioembolic because of that transient myocardial dysfunction which is happening.
Was the lumbar puncture done by any chance, as Dr. Namrata has asked?
I don't think so because she was
lumbar
quite
puncture,
unstable initially.
Yeah, we didn't do it.
If they're coming for COVID positive stroke, changes to still COVID positive cases causing changes. I think from Hina and
I don't remember. I don't think she was COVID positive.
Vivek also is asking for COVID.
COVID negative. COVID and mycoplasma were done. Those were negative.
So, but vertebral thrombosis is definitely there, right? I mean,
Yeah,
it's not a
there.
dissection.
It is definitely there.
Yeah. So that's
Dissection, I will not be able to rule out, Dr. Vita. It might have been a dissection which is resulted in the stroke. The posterior circulation stroke. Dissection, there are some sensitive sequences such as a non-contrast MRI, fat set MRI, T1, or a non-contrast CT, which can sometimes show the thrombus. And if there's a long vertical image, then if there's some tapering of the arteries, that can also point towards dissection.
But do we get dissection in a para-infectious kind of a setting?
No.
It's usually due to trauma, no?
Yeah, too much trauma, yeah.
Yeah.
So we can take it as a thrombus and the supratentorally some small vessel ischemia test to occur due to infection process.
Sure. Okay, thank you.
Okay. The questions was how is the child being treated?
So we did start with Flixane because the whole vertebral artery was thrombosed, and because there is a cardioembolic element as well, and we changed it to rivaroxaban later. And initially we also started aspirin because we were not sure. Is it just thrombosis or is it also a dissection? So later on, then we stopped aspirin. Any other suggestions for the management?
Regarding the unaccustomed yoga somersaults, the child had fever for 3 weeks and she was at home. And just before the dissection, just before this incident, she was watching television. She was sitting on a sofa.
No, Dr. Sridhar is telling if you get a dissection, ask for that history.
Yeah.
Yeah.
So there's,
Okay.
I think there was no history.
Yeah. Any other comments, Dr. Vivek or any other faculty regarding the management? Will it be any different?
There's no history of varicella as Dr. Jain has asked.
Yeah, varicella actually we didn't do. There was, with 3 weeks of fever, no lesions, skin lesions, very unlikely that will be varicella.
Do you give steroid?
So in this child, no, we didn't give, I think.
No.
We didn't give.
3 days of pulse steroid won't do harm. If
Mm-hmm.
your procal is normal and there's no acute bacterial infection, I think that's
A
something.
small dose was given, 10 mg was given on the first day, but 3 days was not given.
We didn't give it actually for the stroke.
Yeah, it was not given for the
vasculitis and all
stroke
those
part.
things. Yeah. The PICU people gave because she came in shock. So actually we did a vessel wall imaging also. But again, even after that, we were not sure whether it is a dissection or a thrombosis. 3 MRIs were done actually, one after the other. Once only MRA, then with contrast, and then with the for the vessel wall imaging as well.
But no inflammatory changes in the walls.
Yeah, there was no contrast
Okay.
enhancement.
Okay.
Yeah.
The vertebral artery is more likely a thrombus, but yeah, just these small changes over here. Again, they are very peripheral to be picked up on an angio, I guess.
All these patients, if by any chance they get a CSF done, it's useful to do IL-6 level as well, because I'm just seeing in the MOG severe encephalitis, this is not MOG, so we get very high IL-6 and the methylpreds and IVIG don't work and tocilizumab works. And since COVID, respiratory, we are thinking of all those things, or even a blood IL-6. So because IL-6 is an important pathophysiology, has a pathophysiological role, I feel. And more than IVIG or plasmapheresis, maybe we should now think of tocilizumab and stuff, even, not rituximab, tocilizumab. Because anakinra is not available. Steroid plus tocilizumab.
In fires, we are doing that. In fires, we are directly going to tocilizumab, and even I tried intrathecal dexa this time, and with very good result.
Yeah, there it works, but these things are also similar sort of phenomena must be there. Because in MOG patients, there are 2 types of MOGs, the easy MOGs, neuritis, myelitis, but the mad MOGs, the encephalitis, or, so they have very high IL-6 levels in CSF. And you give tocilizumab, they improve. So maybe in these patients also, we should do IL-6 levels.
Actually, we didn't go into the vasculitic.
Blood IL-6 also we can do. I'm just sharing an article by Dr. Suman Das. Such a good article he had written in Journal of Child Neurology on stroke and infection in our country, so people can have a look. It's a very good article, how to evaluate these patients.
Sure. Thank you.
All right, thank you. I think as Dr. Ek is there, maybe we'll move over to his case. Dr. Ek, over to you.
So I've just seen the scans and a video of the baby. I haven't sort of been involved in the management of the child. So is a 34-weeker baby who was 1.3 kg, unfortunate perinatal period with bradycardic, gasping, and ventilated for 6 weeks, diagnosed with severe congenital pneumonia, and then was well for a few months, and then again had an episode which was unexplained, unable to arouse, cynos, recovered. So two major incidents, and the child was well for the next 4 months. There were no issues. And then over the few weeks, parents noted that he had developed leptosis with no pupillary reaction was normal. There was left pupillary exotropia as well. And there was no variability to the ptosis, and there was no history of any intercurrent illness or fever prior to this illness, just the ptosis. And there was no limb involvement. So the MRI and the CT follows.
All right. So there is only one abnormality on the MRI. Focus over here along the midbrain. You see the T1 flare non-contrast sequences. You can appreciate that there is a focal lesion out here, a ventral to the left cerebral peduncle, left midbrain. T2A sequence is iso-intense, slightly hypo-intense out here again. Non-contrast T1 again, it is iso-intense. No mineralization or hemorrhage. On the diffusion sequences, this focal area demonstrates restricted diffusion. And if you see it going along the x-axis space, and this is a non-contrast CT. So non-contrast CT, it is slightly hyperdense. So a focal lesion, a ventral to the left cerebral peduncle along the interpeduncular cistern, along the trajectory of the oculomotor nerve. This is the Sag demonstration of the lesion. You can see here the focal lesion out here, ventral to the midbrain in the x-axis space. Contrast sequences, there is some degree of enhancement. These are the MRI contrast sequences. And then we have the CT contrast sequences, again demonstrating some degree of enhancement. This is just an outlook of how the location of the cranial nerve, oculomotor nerve. So it is in the location of the third oculomotor nerve on the left. So as Dr. Vivek had shared the case, I remember one of these cases just seen a couple of years back. This was a 6-month-old child. Similar imaging features, non-contrast CT and hyperdense lesion. These are non-contrast MR sequences on the first two panels. Again, similar appearance of the lesion, restricted diffusion. On post-contrast, there was some degree of enhancement. Then the child had a 3-week follow-up, and a 3-week follow-up, you can see that the lesion was significant, has significantly progressed in size. There was some internal bleeding, but the size had significantly progressed within a 3-week period. At that time, the differentials considered were schwannomas, meningiomas, ATRTs, and vascular malformations. This case, the companion case, was the case of third nerve ATRT, and the main clues were restricted diffusion, calcification, hemorrhage, and especially the considerable interval change in growth in the follow-up scans within a 3-week period. And again, there were similar paper which also had description of these lesions. 3 cases. I think this was from St. Jude. From Dr. Gautam Patai, again, similar appearance along the oculomotor nerve, focal lesions with restricted diffusion, some degree of enhancement. Think of ATRTs. And that is what we're thinking in our case is the prime differential. Schwannomas is a differential, but given that the significant restricted diffusion and the location and the contrast uptake, we're thinking of ATRTs as the primary differential for this case. Now I'll open the case for the panelists if they have any further comments.
Would that be also a schwannoma or a lymphoma?
Schwannomas usually they don't show the diffusion pattern again. Lymphoma of the nerve, it's along the nerve. That's schwannoma is just differential, but I'm thinking ATRT because of the diffusion and the the hyperdense appearance on the CT. Schwannoma usually don't have that appearance.
Anyway, it's something not nice to have. What are the plans? Follow-up or biopsy or?
Yeah, I had sent to the neurosurgeon, and they this week were planning to biopsy it. It's just unfortunate the child came out of 2 major illnesses in his first few months and was so intact and then has this.
What was the age, Dr. X? 6 months, if I'm not mistaken, or 4 months?
Yeah, 6
Okay.
months.
Yeah, same. So all the three cases which were reported were in the infantile period. Maybe a follow-up stage, you can maybe see if there is significant progression, but I think the child definitely needs some degree of intervention.
Thank you.
Sridhar has mentioned schwannoma, and I think Manoj also has mentioned ATRT. I think spine wasn't screened, Dr. Namrata. Is that right, Dr. Vivek?
Yeah, not screen.
Yeah. Yeah. ATRT, poor prognosis. Yes, Sridhar, I agree. Okay. See, to our next case from Pune. Yeah, just to point out it, this was an article published in 2023 recently. I didn't have access, but if anyone can have access, you can go through it for vertebral artery dissection. All right, Krishnapriya, over to you.
This is a 12-year-old boy. So his symptoms started when he was when he was 8. At 8 years, he had a fall in the bathroom, which could be a seizure unwitnessed. And gradually, over the next 2 months, he developed difficulty in walking, balancing. His handwriting changed, and he became irritable, and he started showing aggression. On examination, at that time, he had a normal memory, but he had issues with calculation and comprehension. And he had spasticity in the lower limbs with exaggerated deep-throated reflexes. His fundus was normal. His background is he has a negative family history, a normal 3-year-old brother, non-consanguineous marriage, and normal birth and development. Except for he had bilateral CTV at birth, and serial castings were done till 6 months of age, and it was said to be improved. And his motor milestones were normal after 6 months of age. Then during this episode at 8 years, an MRI was done, and the MRI is there.
Okay.
This was the MRI.
Some degree of cerebral atrophy, particle volume loss, but again, changes of bilateral hyperintensities along the posterior perimeter, deep extending up to the subcortical white matter. In the centrum, some the parietal lobes, the temporal lobes, and occipital lobes. Yeah, so predominant white matter changes in the mid and posterior cerebral hemispheres, and over a background of volume loss in the supratentorial brain parenchyma. Diffusion varied sequences, I think only the region out here or the abnormality out here in the right temporal-occipital region demonstrates some degree of diffusion. Some reversal out there, but I think rest of the, I don't have the sequences, I mean, the planes of the rest of the white matter abnormalities on diffusion and ADC. So I think this is the only focal abnormality out here. Spectroscopy was done. I cannot appreciate any diagnostic peaks. There's normal NAA peak, choline, creatine. The peaks, the ratios are normal. But I think the peaks are kept in the basal ganglia and not in the abnormal white matter. So, okay. After that, I think we had a follow-up. Yeah, it should be out.
Yes. Then what the parents said is that the child gradually improved over the next 2-3 years, and but he had some significant scholastic decline, and the CTV part of his feet it worsened, requiring surgery. And recently, at 12 years, he had a history of fall, or it could be a seizure again unwitnessed. And that same day, he had fever, which was mild, and a witnessed seizure was there, GTS, with uprolling, which lasted for around 5 minutes. And the child went to sleep. It was at night. The next morning, he woke up with complete loss of vision, and he was very encephalopathic. He was not recognizing his parents even initially, and he was having irrelevant talk. And on examination at admission, the encephalopathy was moderate grade. He was recognizing mother by voice. Irrelevant talk continued, and bilateral loss of perception of light was there. And his lower limbs were spastic, dependent reflexes were exaggerated, and planars were extensor. Again, an imaging was done at this point.
So any Was an EEG
Yeah.
done by any chance?
EEG was not done at this point. He was very
Okay.
irritable, and after a few hours, once he was stable, an EEG was done, which was showing moderate encephalopathy. It was a low amplitude EEG, and his encephalopathy improved overnight. And by the next day, he had light perception, and we started IV MPS.
All right. We'll see the follow-up MRI. Then we'll get back to the discussion. All right. Follow-up MRI. Again, you can appreciate the white matter changes. Possibly it's mild progression anteriorly, but you can see appreciate again there is posterior, mid, and posterior stable white matter. Demonstrate these hyperintense changes. Again, there is some degree of volume loss in the supratemporal brain parenchyma. The basal ganglia possibly slightly hyperintense in comparison to the first time. The inferior cortex on either side also demonstrating some degree of hyperintensity. The medial temporal lobes on both sides, again, they are hyperintense on flare. So some degree of imaging progression. The white matter changes little similar, but now the cortex is also demonstrating these edematous changes or hyperintense changes. Again, zoomed in images, again, we appreciate the abnormalities of the white matter over here. I don't have any other sequences other than these coronal sequences of the optic nerves. Was it reported as the optic neuritis by any chance, Krishnappriya? What are you trying to
Yes,
point?
sir. It was
all right.
mentioned as subacute optic neuritis.
Got it.
Subacute, it was mentioned.
All right. Yeah, you can go with this
Yeah.
slide and then
So,
we'll go to the discussion. Yeah.
yes, he did not have any fever during the course in the hospital, and his vision and encephalopathy improved with pulse MPS, but he still had irritability and irrelevant talk. Color vision was improving, and he was walking. He was already walking with a walker after the surgery. Investigations wise, CSF showed one cell, which was lymphocyte, proteins 37 and sugar 67 over a blood sugar level of 108. B12 was on the lower side. NCV was done, which was reported as normal. And MRI spine screening also was done, which was reported as normal. CPK-NAC was 105. CRP was 20. Total counts were on the lower side, 2000, with neutrophils of 54. Renal and liver function tests were normal. CSF and blood cultures were sterile. Electrolytes were normal. And basic metabolic screening was done, which was negative, including blood ammonia, 53. A VEP was done, which showed bilateral dysfunction of the optic nerves with a low amplitude as well as prolonged latencies. CSF oligoclonal bands were sent and IgG were sent, thinking MS also. We considered a lot of DDs at this point, and NMO and MOG are also awaited.
All right. Just a question. Any possibility of SSP for the child?
There is
I mean,
no
the white.
history of, yes, that is also being considered. The EEG which was done was during the encephalopathy stage. We couldn't do a interval EEG yet. This child just got discharged, but we are
Okay.
planning to do an interval EEG as well. He doesn't have any history of myoclonic jerks.
Okay. All right. Yeah. And autoimmune panel by any chance? I think spectroscopy wasn't done. We don't have a
This time
mitochondrial.
MRS was not done.
Yeah.
Autoimmune panel,
I
other
think
than
not done.
NMO MOG, not done.
Yeah. All right. Okay. Yeah. I'll open the case for further comments. I think already people have commented on the chat. You can see. Question of CSF, lactate, Manas, Dr. Lokesh asked for CTX, mitochondrial possibility, SSP, LBSL, CSP, CSF1R mutation from Dr. Sunitha. Okay.
I don't have any good suggestions. It does not look like ALD. Still, I wonder whether you should consider genetic testing in the broad sense, trio exome, for any genetic white matter disorder.
Any family history of inherited neuropathy? Vishpriya from Dr. Namata?
No, sir. There is no family history.
Okay, Romit says SSP likely. All right. I think maybe we can get a anti-measles antibody tested done. I mean, there are
No,
standard tests.
yeah, we haven't checked for the measles part.
Okay.
Because the EEG was completely, there were no spike wave discharges. It was completely a encephalopathic EEG.
Yeah, EEG did not show any periodic discharges at all.
Okay.
It was, yeah.
And B12 deficiency caused this? Because Romit, did you have a case, similar case? I think he mentioned somewhere hyperpigmentation. But I think the changes were more in the frontal area. So it will be very surprising, but I think Romit had similar patient who had B12 deficiency, encephalopathic improved.
B12 can cause it, Dr. Vivek, but usually there is some degree of cerebellar atrophy also. I don't think we have the cerebellar.
There isn't. There is
In this
atrophy.
child also there is a mild, prominence of folia is there.
I don't
And
have the
B12
cerebellar.
was deficient both times. Both times correction was given as well.
And clinically, it would explain the entire.
Yeah, because I remember Romit mentioning a similar situation and giving B12 improved the child's encephalopathy.
Yeah, B12 and the covalent pathway disorders, I agree, Dr. Vivek. I mean, I don't have a cerebellum cut over here, but the other changes can be seen in B12 deficiency.
But can it cause a sudden loss of vision like this, acute?
Yeah, that is what I wanted to know. Does the entire clinical spectrum fit into B12?
Will the spine screening be normal if it is B12?
Yeah, B12 spine can still be normal. And any chance of partial biotinidase deficiency, partial, that also causes vision loss and there is a mild, just sort of.
Usually they will have basal ganglia affection, no?
Not in the partial biotinidase deficiency. I think so. I think Dr. Nilu is there as well. They had few cases. I'm not sure if she's around.
With occipital predominance?
Yeah, partial vision loss with, I'll need to check, but they just partial biotinidase deficiency presence in later childhood with encephalopathy, vision loss.
Is written corticospinal involvement. I mean, we've anyway started with the cocktail, assuming it may be mitochondrial, it may because something which is not really explained completely. I mean, we initially thought it may be relapsing remitting MS, but the MRI changes are too symmetrical and not really fitting in that.
Yeah, the biotinidase deficiency can do that. Present one child we also had with who was treated as remitting relapsing demyelinating illness, and then he came with the progressive visual loss, and then he was diagnosed to have biotinidase deficiency. He had myelopathy plus CNS involvement.
Okay. So we have anyway started with the cocktail, and we'll be sending the. Right now we treated it like with steroids and all, but we are planning to send the exome studies. No, we have not done measles IgG. The EEG is not at all suggestive of SSP.
Dr. Kavita, we also
anyways, CSF IgG we have sent, so even if that is increased, that can also help us. Sorry?
So we previously also had one case from Dr. Divani where the EEG wasn't statistic, it has only slow waves and cystic changes in the brain. That turned out to be measles, progressive abnormalities clinically and radiologically. So I'm not sure how specific or sensitive the EEG is, but if you say so, then I would leave it to you.
Yeah, SSP we had kept as a DD, but the only thing, because the EEG was not at all suggestive. We'll see if we have an extra sample. But when we have a IgG which is increased, just like we are using nowadays anti-rubella antibodies in the CSF as a surrogate marker for MS. Similarly, probably the anti-measles antibody may also be high. It's just telling us that there is a increased intrathecal synthesis. So I don't know how specific it will be in this setting. Because nowadays rubella antibodies are being used in the CSF as a marker for MS. So that is probably just a surrogate for increased intrathecal synthesis. If somebody is a specialist here in MS, maybe they can come in.
And here you had 2 episodes 3 years apart, right?
But yeah,
2
4 years
episodes.
apart.
Yeah,
Yes, sir.
so
4 years.
Actually, the
SHP would
previous
be
one
very
was
unlikely.
not like an acute episode. The previous one was a little slowly progressive. So from 8 years, it was there, and slowly it manifested with cognitive decline, difficulty in walking. So the spasticity is there. So that was probably a subacute process. And then this loss of vision is quite acute. This one day.
SSP, one seen loss of vision, like optic neuritis and improvement suddenly, they might, so that is all.
And the very fact that he improved after steroids, though they can have, because Rajalakshmi madam in Padia, she had mentioned, they had a couple of cases who came with loss of vision. And the jerks and all started coming later. But such an acute loss of vision and no suggestion on the EEG, very unlikely.
Did this child have no conduction studies done? Because if he has an underlying, leukodystrophic, leukoencephalopathic process, which is affecting both the central and the peripheral myelin, we might see changes in his nerves too. Because, like you said, it's a subacute process. So the question is whether he had an acute decompensation following whatever infection he had, which caused the changes.
Yes, ma'am. When NCV study was done, it was normal.
Okay.
NCV is unlikely to show changes. He was spastic, right? Hyperreflexic.
Right. Right.
So that is not
Yeah,
going to
he
show
has
changes.
UMN signs, yeah.
Yeah,
Yes.
because that will only show changes in leukodystrophies when your reflexes disappear, right?
Right. Yeah. And we had a biotinidase deficiency recently who came with bilateral foot drop, actually. He was a non-biotinidase deficiency. And for some reason, his biotin source changed. So I don't know how much he was actually getting bioavailability wise. And he came with bilateral foot drop. So it's worth exploring. At least it's a treatable etiology.
Okay, sure. We'll get back to what we actually ultimately arrive at.
Okay.
Thank
All
you
right.
very much.
Thank you. Thank you. All right, Amas, over to you.
Hello, good evening, sir. So it's a 12-year-old female child. She presented with history of fever for 2 weeks, for which they had taken treatment on OP basis. Then she had sudden onset decreased vision on the left eye after waking up from sleep. When she came to us, she had left-sided RAPD. Visual acuity, light perception was decreased in left eye, and right eye was 20/40. There's exaggerated DTR and bilateral ankle clonus. So in 2019, she had similar history of fever for almost 20 days, followed by decreased vision in both the eyes, painless vision loss. So we don't have the MRI films, but reporting is available. It was treated as like a demyelinating disorder, but the NMO MOG were negative. She also received 3 doses of rituximab, and then she was lost to follow-up.
Okay, so I have the recent MRI. I have only the films. Okay, these are non-contrast phase sequences, slightly degraded in quality, but you can appreciate there is some degree of cortical subcortical edematous changes in the bilateral frontal lobes out there, in the right parietal lobe there, along the cingulate region. Some periventricular hyperintensities, anterior and posterior periventricular hyperintensities coming down along the inferior aspect. The basal ganglia appear to be relatively normal, thalami normal. I'm not sure if there is some signal abnormality on the temporal lobe out here. In comparison to the left, you can see it is slightly more hyperintense. And the midbrain on the left is showing these hyperintense foci. So cerebellum, I cannot again appreciate based on the quality of the SET scan, but I think it looks normal. So there are multiple subcortical cortical hyperintensities in the frontal, parietal, temporal lobes, and also brainstem involvement, and periventricular white matter and deep white matter involvement. Post contrast study, again, patchy areas of abnormal enhancement in the right parietal lobe, the temporal lobe out here. I'll come to the optic nerves, but yeah, these were the main changes on the post contrast brain sequences. Optic nerves, the left optic, especially its bilateral edematous changes, but left is more severely involved in comparison to the right. And again, on the contrast sequences, you can appreciate the degree of enhancement, the long tract enhancement on the left side, some perineuritis on the right side. Scan sequences, again, could not appreciate, I mean, the quality of the scan is slightly degraded, but could not appreciate any significant lesions along the midline structures. Some degree of volume loss, supratentorially and also in the cerebellum. All right. So this was, I think, Anas has already mentioned. MOG and NMO was negative. I think we have sent a MOG and NMO again, thinking of demyelination. The question was, do we send for oligoclonal bands? And Anas, do you think it fits into any of this algorithm? First demyelinating event in 2019, zero negative, I assume.
Yes, sir. The previous MRI, it showed, I mean, we don't have the report, but the films, but it was reported as T2 hyperintensity in the ventral midbrain and bilateral thalami, caudate and putamen, as well as periventricular white matter, as well as bilateral temporal mesial temporal lobe hyperintensity.
Okay. Yeah, I think all the three bands to be sent, but I'll open the case for further suggestions. Spine wasn't done, no?
No, sir, spine was not done. They had come with imaging done outside. So we just admitted for evaluation.
So main question is, do we have to send oligoclonal bands along with NMO and MOG?
We have sent oligoclonal band as well, but only thing is it so like a Adam phenotype, because last time NMO MOG was negative, or it could be something else, because though we have started steroids and she has shown a partial response. We have given 3 doses and the vision, there's improvement in the vision. Only thing odd was the asymmetrical involvement. Clinically, her vision in the right eye was much better and left eye was much worse. So the stark asymmetry was something that we were concerned about.
Do we know how her mock testing was done the first time in 2019? Was it done with a live cell-based assay?
We don't have that, ma'am, but we don't. So this time we have sent it to Amrita lab.
Right. I mean, her clinical history sounds like she had bilateral optic neuritis in 2019, which responded well to immunotherapy. Then she was asymptomatic for 3 years in between, or 4 years. And then now this lesion looks like a longitudinally extensive anterior optic neuritis in the left eye. The only thing which goes a little bit against the history is the painless loss of vision in the 2019, but we don't know if we have the correct history. Because even now, was it painless? Even now, this presentation, was it painless? Because usually pain is a signal.
There was some pain.
Right.
There was some degree of pain, but not very disable.
Yeah. It sounds like an inflammatory optic neuritis. I think MOG is definitely high on the list, especially with the other changes on the MRI and the ADAM-like findings. So I think definitely among all three, MS, NMO, and MOG is, and her age also, right? She started off in 2019, so she's about 9 years old at that time. So probably MOG is still highest on the list. So we want to make sure we collected the MOG before the treatment and that we sent to a lab which does live cell-based assay. Because sometimes MOG may be negative the first time, and if you repeat it the second presentation before starting any form of immunotherapy, you will probably get it positive this time.
And ma'am, the asymmetry is also, is it?
It's possible, yeah. And I mean, in younger children, bilateral is common, but now she's more a recurrent process, right? This is the second presentation. So I think this time, it's possible that this is unilateral. And the other thing, I don't know if you have possible, is to getting optical coherence tomography. It's just more for follow-up. It's not going to give you a diagnosis, but it will show thinning in the retinal nerve fiber layer on the other side, which is presently looking normal, the right side.
Okay, let's get back to us with the results. Thank you, Dr. Namrata.
Thank you.
Yeah. Sorry, yeah, these are just the optic nerves, involvement of optic nerves on various diseases. NMO, Davic, more anterior pathways, proximal pathways, MOG, more perioditis, and MS, more unilateral. All right, Anand, go to you.
Yes. So this is about a 14-month-old female child born to non-consanguineous parents with uneventful perennial history. She had attained independent walking and bisyllable by one. It's a male child, sorry. Had attained independent walking and bisyllable by 12 months, development normal. They are from Somalia. So 2 months earlier, the child had fever for 1 week. Was hospitalized for the same in the country. Diagnosed as malaria. They had fever and chills. After recovering from the fever, there was sudden onset weakness of lower limbs, more than upper limbs, noticed in the form of inability to stand or even crawl. The child was able to briskly walk, and now he's not able to even crawl. Since then, he has been gradually improving, but still not able to crawl. There's history of constipation, but urination is fine. When we saw the child, child is quite alert, interactive. There's no cranial nerve deficit on examination. There's a left hand preference. Bilateral knee jerk is exaggerated.
All right. Okay, so the MRI was done at 2 months after the fever, or sorry?
Yes, sir. MRI was done recently, I think February 1st.
So 2 months after the onset of fever.
Yes, yes.
Okay. All right. These are, I think, again, slightly degraded pixelated images, but non-contrast sequences, P2 sequences, you can appreciate some degree of hyperintensity along the cord. It is not swollen, but you can appreciate it's more on the central and ventral aspects in the cervical region and also in the lower thoracic region. On the axial sequences, more centrally and the anterior columns are involved along the cervical segments. I don't have an axial on the lumbar thoracic spine, but yeah, these are the axial sections on the cervical spine. Post contrast was done. The cervical lesions did not demonstrate any enhancement, but there was some degree of choroidal nerve root enhancement. You can appreciate on the axial sequences out here, more ventral choroidal nerve roots are demonstrating this degree of enhancement. Also on the sides, you can see that there is slightly hyperintense on the post-contrast study. Brain was done. I have only 2 sequences, that is the diffusion and the flare sequences. The only abnormalities I could find was these changes along the dorsal brainstem, the central tegmental tracts, and the dorsal pons and the medulla demonstrate some degree of edematous changes. So if you concentrate on the cord, I think our child has predominant changes along the ventral aspects and in the central regions, and these are the differentials one can think of, ranging from post-viral infection to demyelinating etiologies such as NMO and more likely NMO and MOG, and acute flaccid myelitis if the child has the clinical symptomatology. That is the differential we're thinking about. Enterovirus from encephalitis pattern also could be there, but I think just the 2-month period was slightly, I thought was an outpoint. I'll leave it to the clinicians if it fits or not. So yeah, these are the images we have and the clinical presentation, and I wrote in the case.
Yeah, there was no severe pain reported at the time of the weakness, at least. So main question was the extensive involvement of the neuroaxis, brainstem as well as spinal cord. We were thinking, it could be just acute flaccid myelitis, like in that spectrum, or do we work up for demyelinating etiologies? We have not sent any workup as such at this point of time.
Okay.
But was the CSF done? A lumbar puncture? Sorry.
No, ma'am. So it was not done in their hometown.
Okay.
They don't even have any reports with them. All they have left in Somalia. Only MRI, they got it done here in India. So wondering if it's worth getting evaluating.
So there is predominant gray matter involvement in the spinal cord, and like Dr. Reddy mentioned about the cervicothoracic area and the conus area, the lower spinal cord, that could still be in keeping with MOG and with the history of fever and everything. I think although the brain is negative, you want to consider myelitis, MOG positive myelitis. So I would definitely send MOG in this child. Have you treated him with any immunotherapy?
Yeah, we thought we'll just get a consensus and then.
They came almost 2 months after this one, only last 2-3 days back to the OP. So we thought we'll have an opinion and then start.
Does he have reflexes now, or he's still flaccid and areflexic?
He is quite flaccid, but he has reflexes.
MOG is in
Yeah.
fashion. I mean, you discuss MOG in every patient, understandably, as you do COVID, but I'm in favor of just a kind of normal viral myelitis. In terms also of epidemiology, I think at this age, this is probably more common. It's just a thought.
Yeah, I agree.
Thank you, ma'am. Thank you.
So,
I will give the update.
all right. Thanks, Gus. Yeah. Anas, what do you?
Yes. So it's a 1-year-old child with a global development delay, microcephaly, and epilepsy. So birth history is a twin pregnancy with term gestation, low birth weight 1.6 kgs. There's perinatal history. There's no history of any birth asphyxia, but ICU admission, NICU admission for in view of low birth weight. The other twin is quite healthy.
All right, term just okay. All right. MRI done at 1 year of age, if I'm not mistaken. And you can appreciate that is the pontocerebellar hypoplasia pattern on the sagittal sequences. Some hyperintense areas on the pons. The cerebellum is completely hypoplastic, maybe atrophic too. The cortex is slightly hyperintense on the T2A sequences. There is some cystic foci along the periphery in the inferior cerebral hemisphere. Better appreciated on the coronal sequences out there. The gyral pattern also I thought was slightly simplified for a 1-year-old child. We have other sequences, better demonstrate that. I could not find any foci of hemosiderin on the SWA sequences. That could be a possible marker for an antenatal injury. So yeah, here are the supratentorial sequences, and you can see that a simplified gyral pattern in the frontal lobes out there, temporal lobes, better appreciated on the coronal sequences for a 1-year-old child, and you can see the contrast of the infratentorial structures in relation to the supratentorial structures. So brainstem hypoplasia, cerebellar hypoplasia with a degree of simplified gyral pattern, cerebellar cortex hyperintensities with some cerebellosis. Whole exome was done. Unless is this a VUS or a pathogenic or likely pathogenic? Yeah. So I put it as VUS. Okay, VUS. All right. So PCH 15 of CDC 40 VUS variant was on the whole exome sequencing. Then we looked at the presentation of the PCH 15 that is due to the PRP17 or CDC 40 related genes. Imaging wise, at least that the child has pontocerebellar hypoplasia, corpus callosum abnormalities can be seen, brainstem hypoplasia can be seen. Enough any idea of hematological abnormalities, anemia, thrombocytopenia?
No, he doesn't have. And was it a autosomal recessive, but a heterozygous hit to Anas?
It was a heterozygous, sir.
Yeah, so it doesn't actually. So we don't have a complete answer. It was just heterozygous hit. So we don't have a genetic answer.
All right. All right. Yeah, I wasn't aware, but there's only one case report of the described gene. This was the imaging presentation for that. Yeah, I'll open the case. Again, just differentials for pontocerebellar hypoplasia, cerebellosis can be seen in 1 to 6 variants and muscular dystrophies. And supratentorially simplified gyration can be seen in these genetic disorders. Though the renin pathway disorders have elobulated or incompletely elobulated Burmese, which was not seen in our case. So it doesn't quite match the imaging wise, at least of these disorders. But we're lucky to have Aigen if he wants to throw some light on the imaging pictures and also the clinical presentation and other panelists to comment upon.
As you said, this is a form of pontocerebellar hypoplasia. Type 15 is extremely rare. Of course, I have no personal experience. Just if you look at the coronal T2 here in the top row, you see that large cyst. This is not specific. It has been shown in PCH2, which of course here is excluded, and it has also been reported in patients with coenzyme Q4 deficiency, also a different presentation. But the most PCH do not have cerebellar cysts.
Again, just the question is, thinking of genetic more than acquired cause, would the cyst be explained by a plastic process?
Can you repeat the question?
Would the cyst be explained by any ischemic changes, like a cystic encephalomalacia, and the entire PCH is a post-antenatal injury instead of a genetic cause, or we are thinking genetic more than acquired?
I'm not sure whether I understand your question. Are you referring to that cyst?
Yeah. Is the cyst is it
I can only refer to a paper by Peter Barth. They looked at cysts in diseased patients with pontocerebellar with PCH2, and this is kind of a degenerative cyst. It's not a primary cyst. It's considered to be secondary destructive.
Got it. Yeah. So how do we process, because whole exome has not picked up any genetics of pathogenic variants? Do the parents get tested now, Dr. Lokesh, or we ask them to reanalyze, but we're not sure which gene?
Yeah, I've been trying to reanalyze, so they're trying to get some inputs in the meeting so that we can get back to them with this information.
Okay. Well, all right. Yeah, I don't think I have any further comments. So
it's like a PCS spectrum, likely genetic.
Yeah. That's right.
Thank you.
Okay. All right. Next two sets of pieces from Dr. Samya. Dr. Samya, if you're there.
Yeah, I'm here.
Yeah.
So this child is a 4.5-year-old who has hearing loss, severe hearing loss, for which the child they're taking treatment. Also has short neck and other dysmorphic features. Other than that, hearing loss and then speech delay. Otherwise, the child was well cognitively. This child suddenly had normal acute febrile illness. And then at the third day of illness had some, according to the referral doctor, some shiverings, and the parents are telling one episode of seizures that they have witnessed, but it was referred as status and multiple episodes of seizures. But after coming here, the child did not have any further seizures, and the child has improved in sensorium wise quickly only. So then CSF was normal. Other pointers to infection were not there. My main doubt is in the MRI.
No cranial nerve abnormalities, no?
Sorry?
No cranial nerve palsies or anything.
No cranial nerve palsies.
Yeah. Okay, all right.
Yeah.
Okay, so the MRI, again, predominant changes in the posterior fossa. Supratentorally, the structures were normal. So there's this focus in the lower medulla along the paramedian aspect on the right side is demonstrated this focus of restricted diffusion. Again, on the T2 weighted sequence, you can appreciate the focal T2 hyperintensity out there. But if you see on the lower, if coming down inferiorly, the medulla also is slightly bright, it's slightly T2 hyperintense. There is a partial clefting along the dorsal aspect of the medulla, but again, structures are hyperintense in nature. There is some degree of edema out there. No mineralization or hemorrhage on the SWA sequences. Sorry, Yeah. So on the SAT sequences, again, you can appreciate that focal abnormality out there. But if you see lower down, there is some degree of edematous changes along the dorsal aspect of the medulla cervicomedullary junction. So mixed edematous type pattern with this focal area demonstrating repeated diffusion. Post contrast, there was no enhancement. You can appreciate the vertebral abnormalities, segmentation anomalies, which are commonly seen in the triple field related disorders. But the main question I think Ramya has is this infective process with small vessel ischemic changes, that focal area demonstrating small vessel ischemia, or is it related to
Yeah.
is it in infarct, only an infarct and not any inflammatory changes? Is that right, Ramya?
Yes, yes. I mean, how to take this infarct as and how to go about with the treatment. 2D echo is normal in this kit. My main doubt was whether any MRA was also done, which is normal.
But it is unlikely to pick up.
Yeah.
The MRA.
Obviously, it's very small.
Yeah. So I'm
So,
thinking it's an inflammatory process with some, secondary ischemia, small vessel ischemia there. If it was only infarct,
can
then
the
these
diffusion?
changes would
Okay.
not be there. The cervicomedullary changes, the medullary changes. It was only infarct out there, but there are some additional edematous changes out there. So, and the child had this infection of either
No, CSF was absolutely normal,
CSF
and the
normal.
child didn't have any clinical features suggestive of cord involvement. By next day, the child was all good. Sensorium was also good. No, this one. So whether in triple field, is there any association with this infarcts? I wanted to know, and how to go about the treatment was my main doubt. Considering it as a small infarct, I have started aspirin. But anything else that I need to think of or do?
Okay.
Nihaal, may I come back to the previous slide?
Yes, please.
Axial. In the middle, is that kind of a spinal dysrhythmia? It's kind of almost a diplomyelia, is it?
You mean this part?
Yeah. And if you do the sagittal through that area, it mimics a longish T2 hyperintensity, which is not, in fact, an infarct, just CS.
No.
No?
That is not the infarct. No, that's not the infarct. This one over here.
It's just a tiny infarct, isn't it?
Yes. But
Yeah.
this, if you see on the T1, it is not the CSF. It is, you can see the cord is intact out there. And that corresponds with this area, the non-enhancing component.
I'm still confused.
Yeah, the axle over here, if you see the medulla here, it is edematous. The ventral aspect, the lateral portions out there.
But in the posterior part of the medulla, you have
It's like a cleft. It's like a
how do
cleft
you
out
call
there.
it?
Deep. I would say
You have
just
a
a cleft.
defect, and this is a
it's a defect out
congenital
there.
defect, isn't it?
Yeah. Yes. That's a congenital defect. That is not in question.
And
the question was.
And sagittal imaging of that defect looks like a longish pathology, but it's not. Maybe I cannot explain what I mean.
No, I understood. You're saying that this is a CSF because of the cleft.
Okay. This has nothing to do with this patient's condition now. This is congenital. So we have just a tiny brainstem infarct.
I agree. But if you see on the T1 out here, this area out here it does not show hypointensity. It is isointense. Or slightly hypointense. There should have been a cleft out here also in this portion.
Dr. Nihaal, do you see those sagittal changes that we are talking in the cord, even in the axials? Then it will be corroborating.
See over here, if you see the areas, I don't know if you see my mouse.
Probably medulla only, right? No.
Yeah, that is the medulla only, and the lower medulla.
No, but we are seeing something in the cord. Is what is one thing mentioned.
So that, he is mentioning. Dr. Aiken has mentioned this part. That could be the cleft, but this part, if you see, it is bright, isn't it? And this area out here.
No, my point is you have mentioned that the cord a little more than that much we are seeing in the axial is also hyperintense is what you're mentioning, right?
Yes.
The second image. Yeah. Do you see those changes in axials as well, like multiple sections, 1, 2, 3, something like that?
The
If
element
no,
is yes, yes,
it
you
can
see
be
it.
taken artifactual, right? That's my point. The second
I understand
image,
your point.
that
Yeah. So you are saying it doesn't
talking
correspond
about
with this focus over here.
yeah.
If you say it corresponds, but over here the medulla is again brighter.
Meaning the cord could be artificial, but
Yeah.
okay.
But there is some
So if
degree of
we
edema.
put that aside, what about this infarct? Oh,
I would say it's an
edema.
infarct. I mean, just a small
Okay.
infarct.
Okay. Any other opinions regarding that
Yeah.
infarct?
You mean treatment-wise? Yeah.
Treatment and pathophysiologically also.
Okay.
That
Okay.
we were in previous classes, we were talking about this dynamic MR angiography about the skinking of posterior vertebrae. Those things I wanted to know whether that is relevant here or not.
I mean, child definitely has CVJ abnormalities.
In my limited experience, small brainstem infarcts in the pediatric age are rare, but they can be seen. And the prognosis regarding recovery is quite good. This is likely to be expected, a good recovery.
Yeah, Dr. Eugene, the child doesn't have any clinical features pertaining to that defect as such. There are no. So, there is, I mean, no defects only, I mean, deficits only to start. The child is good.
Ramya, the question, angio was a neck angio done, neck and a brain angio, or only a brain angio?
No, I spoke to the radiologist. He told he has done it, and the vertebral arteries were also seeming. They were all good, is what he told.
Okay.
Dynamic MR angio required here? Not required. That was one more question I had.
The vertebral arteries are normal on the initial, then it is fine, I think. But I think the CT angio will be more helpful, because if you see if there is any bony abnormality going along the vertebral arteries.
I don't know if you got the CT. They have done CT for the neck, not angio. CT neck has been done.
Yeah, that we won't be able to see the arteries.
Yeah.
So maybe a CT angio, you just want to rule out any further events. That will be helpful.
Sure. Okay, then clinically I'll follow up and do whatever will be required.
Got it. All right. Let's see if any further comments there are. CT with bone, Manoj, Jayan says CT, dynamic CT angio. I think.
Next stress in KF can be on.
Yeah. So maybe on a follow-up, we can get a dynamic CT angio.
And this child was intubated as well. Probably neck meddling could be one reason. Yeah. Okay, thank you.
Yeah.
And sorry, one more question. It doesn't match into any territory. That's I have looked into.
It doesn't.
It doesn't match, right? Yeah. Okay, sure.
Okay.
One more case. So this is a 2-year, 8-month-old child who presented to me on 20th of this. This child had sudden weakness. She started complaining that I'm unable to walk. But then when the child was reviewed elsewhere, they have treated the child as viral myositis. They asked them to come back if the child doesn't improve. But the parents felt that over 10 days period, the child has improved well. That was their perception. And then they didn't come back. On 19th of January, suddenly the child started complaining that she can't see anything. Total loss of vision was there bilaterally. According to the child, total darkness is what she was complaining about. So the next day, 1 day later, they have come to me. Otherwise, the child was well on examination, no encephalopathy. Unable to walk alone, probably because of the visual problem. Otherwise, the power was good in all 4 limbs. No cranial nerve involvement except the second one. Pupils were sluggishly reacting. And then vision was not there at all. And that's the MRI pictures will be.
So this is the latest one, or the first one?
Only
one scan.
One MRI was done.
After the in January or is it in December?
No, they no, sorry.
No, I mean you presented in December and January.
No, December they didn't present to me. That was
Okay,
there.
okay.
They have shown reviewed elsewhere.
No, I just wanted to
They
know the
came
date,
to
the
me.
date of MRI.
Correct. 21st or 22nd, they have visited me.
Okay, all right.
Yeah.
So the MRI, we have non-contrast phase sequence on top. Again, confluent abnormalities in the posterior cerebral hemisphere, the parietal lobe, the temporal-occipital lobe, have these clear hyperintense changes going up to the subcortical white matter. Centrally, if you see along the anterior commissure, there is slight hyperintensity on the right side. A focal area out there in the right frontal lobe. Brainstem, you can appreciate there is a focal abnormality along the dorsal aspect of the pons out here. And again, a focal abnormality in the left posterior temporal lobe. Along the optic pathways, you can see that the right optic pathway, at least over here, is more hyperintense than the left. Diffusion could not appreciate any diffusion changes related to the abnormalities on the phase sequences. Optic nerves, non-contrast optic nerves, bilateral edematous changes, left more than the right. Sad sequences on the spine, you can appreciate cervical myelopathy out there and also dorsal myelopathy. The cervical cord is swollen, and corresponding axial sequences, you can appreciate almost the entire holocord involvement of the cervical spine and predominant central gray matter involvement of the lower thoracic spine. Contrast sequences were done, again, nodular fluffy enhancement pattern demonstrating the intraparenchymal abnormalities along the temporal lobes and occipital lobes, some foci along the right caudate nucleus out there, and along the anterior commissure. I could appreciate only a slight enhancement along the facial nerve, slightly abnormal. The anterior segment should not enhance. Again, the optic nerves, bilateral long tract enhancement pattern, left more than the right, and you can better appreciate of that on the coronal sequences. The left optic nerve is more severely affected in comparison to the contralateral side. Post-contrast spine sequences, the cervical and the thoracic abnormalities did not demonstrate any enhancement. Again, there was some degree of choroid and nerve root enhancement, the ventral and dorsal aspects. Given that, again, thinking of demyelination spectrum, predominantly think of MOG, but the question here was, do we think, is it a sure shot MOG related abnormality given the optic nerve involvement? Or should we also think of NMOSD? The parenchymal lesions are more suggestive of MOG, and yeah, optic nerves, long tract involvement was the question. Yeah, parenchymal abnormalities are of MOG. Again, optic nerves we have seen in the previous slides. Think of MOG in bilateral involvement. NMO also can have bilateral involvement, but more along the proximal pathways. This was a paper I think published a couple of years back demonstrating the optic nerve abnormalities for the various demyelinating etiologies. I'm not sure if we have time enough, but if you see on the chart over here, longitudinal involvement can be seen in MOG-related changes and aquaporin-related changes. Bilateral optic nerve is more commonly involved in aquaporin-related disorders. Again, bilateral optic nerve was seen again in MOG and aquaporin-related disorders. Diagonal involvement more common in aquaporin-related disorders. Intracranial segments again more commonly in the NMO spectrum. But longitudinal involvement can be seen in both MOG and aquaporin-related antibody disorders. Okay, these are the examples, imaging examples. MOG antibody-related disorders, you can appreciate bilateral long tract involvement. NMO also can have bilateral long tract involvement, whereas multiple sclerosis was more one-sided than the NMO and MOG-related changes. And I think many of you have put it on the chat as MOG, and this was the result.
Clinically, also age-wise, all that I was thinking of MOG only that chiasm involvement was little like probably overlapping. NMOSD presentation of MOG, it could be still. And my doubt is, this child had symptoms of walking difficulty like probably a month ago. Then the child had spontaneous improvement and then had this florid changes. Can this presentation be seen like spontaneous improvement and then having like good improvement in 10 days, I should say, because the child was able to walk?
You mean without any medication or
Yeah, without any
steroids?
medication. No,
Okay.
no.
Okay.
Yeah, that is one question. And today the child came for follow-up. After starting IV steroids, the child has improved well. 5 days of IV steroids we have given methylpred, and then followed by oral prednisolone. Now it is 1 week after stopping the IV steroids. The child has some improvement in the vision, but it is still less, especially in the left side. She's just able to see like probably in 10 to 15 centimeters distance. But with both eyes, she's able to recognize objects at some 3 feet, 4 feet distance as well. My doubt is, should I escalate it to IVIG, or will the steroids, should I wait for some more time?
Okay. There's a comment for second line immunomodulators from Sridhar. MMF or other thioprine.
Second line, just into the illness, I think we can wait for that. But my doubt is whether I should start off IV. Initially, I thought if there is no improvement at all by 48 hours, we would go for Plex, was our main this one. But by 48 hours, in fact 12 hours only. Night we gave steroid. By early morning, like morning rounds, the child could able to see light. Perception of light was there. Projection of rays was there in one night. The next day morning, she was able to identify faces. Because the improvement was so quick, we didn't go for Plex. But now it is 15 days after starting the treatment. I'm a little worried whether we have to go for next level, or will this be sufficient and wait?
Okay.
How high was her MOG titer in the serum?
1:10. 1:10 dilution was given.
Okay, I'm probably not familiar with that, but like normally
strongly
1 in 100
positive is the word
above.
used. Was the word
Okay,
used?
okay. Yeah. I mean, usually MOG responds very well to IV steroids, so little unusual for this child to not have as much recovery in one eye compared to the other. Definitely a slow steroid taper, like Dr. Joshi suggested, 3 to 6 months. So within a month, bring down to about 0.5 mg per kg and then stay there for the next 2 to 3 months at least.
Yeah,
question
the
about
child is on
IVIG.
1.5. Yeah, please go ahead. Sorry.
Yeah. Question about IVIG versus Plex. Probably would have considered Plex like you did in at the initial first week after 3 to 5 days of steroids if the vision was not improved significantly. But at this point, I don't know how easy and cost effective, like easy it is for y'all to get IVIG, but it's worth the try. Like at least the European group does do IVIG in these patients. So, and it's a small child. She's only 3 years old, so she probably doesn't weigh as much. So it might be easier to give IVIG. But in general, for the myelitis and bad optic neuritis, steroids and early Plex is recommended.
Even if my doubt was, I was considering Plex by like 1.5 2 days, but then the improvement was so significant that's why I didn't go for it. But even then, is it even if the improvement was there, should I have gone for Plex, or is it okay to wait?
Usually they improve like almost like a 20-25% every day with steroids. So if by day 4, day 5 of steroids, they're pretty close to like this is a younger child, so I don't know how much she can read, but most older children, they are able to read on the Snellen's chart till just 1 or 2 lines below normal. They improve very fast. MOG is very steroid sensitive, especially the optic neuritis. The myelitis is not as sensitive. Yeah. And I know we would just to in this 8 cases that we talked, I know we thought about MOG in almost 3 of them, definitely the optic neuritis, the myelitis, and now again the optic neuritis. But like some of the people in the panel talked about, I think MOG is such a mimicker and we are still learning about MOG. So definitely important to consider MOG early in the differential and test for it because it's going to guide your treatment. We currently have a patient who came with myelitis, a teenager, and she presented to us late, about 10 days of symptoms, and she has not made significant improvement in spite of getting all the first line treatment and is currently on rituximab, but she's still apoplexic. So she probably had more anterior horn cell involvement in her myelitis. So she's still very atrophic, areflexic, and flaccid. So definitely consider MOG early because it's a diagnosis we can.
This child by
be.
the day the child have come, we have considered that, and by evening we have initiated.
Right.
Is it
Yeah,
worth
no,
a
this
try
case
of
is very
IVIG?
typical for MOG optic neuritis. This one is very typical for MOG, especially when the brain lesions, those fluffy, ill-defined lesions with Apache enhancement is very typical for MOG.
In your case, see, there are two places where the lesion is. One is in the eye, and then there is a occipital involvement as well, you know. So the improvement cannot be just, maybe the neuritis will improve, but the occipital part is still affected. So there is occipital involvement, right? In the both white, especially the white matter of the occipital lobe. So at least for me, steroid has not been as quick in few days, and I would still, but I've just the limited experience I have. I waited for a month for the steroid to work, and slowly they get better.
Sir,
In your
should I
case,
go for
in your
IVIG?
case, occipital, no, I won't go for IVIG.
Okay. So we can wait probably for some more time.
Yeah, because see, there is occipital involvement also, dysmyelination. So that might take a while.
Okay.
Yeah.
But we don't know. All of us sort of work on assumptions. But it all depends. Very educated family, so worried, and you are, you know, peace of mind is not there. Give IVIG. But if you know, you understand what I mean.
No, I understand, sir, but no, IVIG for them is like a bit expensive.
Yeah,
I mean,
so that will be the issue. Yeah.
Any other thoughts?
Yeah, maintaining good dose of steroids. Don't do a rapid taper like you're planning to. Like you are planning to do the slow taper. That is a good plan. And repeating an MRI maybe within 8 to 12 weeks. I don't know again how easy it is for the family to pay for a new MRI in 3 months' time. And repeating the mock titer like somebody suggested at 6 months is probably the easiest plan. If he has any recurrences in between, then of course you're going to have to treat earlier and consider second-line treatment.
Okay.
So first episode you won't give, right? After this one you won't need immunomodulation as was mentioned.
No, not after this one.
Yeah.
Not after this
And
one. But if he has recurrences.
Yeah, what I have been doing is not to stop it in 6 months, even with the first episode, take 12 months, very small dose, and just keep doing MOG every 6 months. As soon as it becomes negative, just stop that small dose also. But that's just my personal practice. It's not been published anywhere, and somehow it has helped to prevent the recurrences. So that 6 months, what has been published for the first attack, instead of that, you just give a very small dose, 0.3 mg per kg alternate day for 12 months to prevent the complications. And somehow for some of my patients, there haven't been recurrences because I've been able to get them up till the stage where MOG became negative after every 6 months. Just a thought.
Dr. Namrata, after a week's time, if I repeat the exam and still there is some positive response, but not totally, is that consider like further treatment, or still can I wait?
I think cost is going to be probably more important because here IVIG is very expensive, and but the family is able to afford, and if the vision is not getting better, it's worth considering IVIG. It's not going to hurt her; it's probably going to help her because you're already on a low dose of how much you are getting, 1 mg per kg.
No,
right
1.5 mg per kg I'm giving for 2 weeks. I planned that, and then 1 week she has already taken. Today is 1 week. Today they have come for this one. Temporal pallor has set in, but there is no papillitis.
It should get better with steroids. Most MOG is steroid, especially optic neuritis is quite steroid responsive. So I think next week will be a better vision acuity, and if not, then consider IVIG. I think every week you'll see an improvement.
Yeah. Okay. Thank you. Thanks everyone for all the inputs.
Yeah. All right, we're done with the new cases. I have 2 follow-up cases from previous discussions. We'll quickly go through them. Grishma, if you're there, can you quickly summarize? Yeah.
Yeah, this is a 6-year-old boy, third child of non-consanguineous marriage, admitted with status epilepticus. He had neonatal onset seizures, used to get seizures once in 3 months. Last 1 year, he had monthly recurrence of seizures, predominantly left focal, had speech and mild motor delay. He was going to school. In this admission, he had seizures followed by fever on day 4 of illness. There was left focal seizures. He was ventilated outside, was on 4 anti-seizure medication. On extubation, again he had seizures, so intubated and referred from outside. MRI brain plain done was normal except for a retrobulbar cyst. Due to poor GCS, MRI done with contrast on day 5 of admission, which was considered demyelination and started on pulse steroid, CSF done, which was normal. Large doses, so that MRI actually we discussed in the previous meeting, and we gave.
Sorry, go ahead.
We gave large dose of thiamine and biotin. Initially, he got showed a dramatic response. He became awake, respond to call. Dystonia and rigidity of left upper limb was there, but his full seizures were controlled. But after the initial improvement, there was not much improvement. Only seizures were controlled. The severe dystonia and his rigidity, everything was persisted. Currently, sensorium is better. He has persistent upgaze. There is not much head control, and there is spasticity. So again, he is discharged now. So just before discharge, we repeated one more MRI. That we will discuss. That showed severe brain atrophy with vasodilation of ventricles. And meanwhile, we got the genetic report.
Okay, let me show the MRI first. I think I have the interval MRI, the intermediate MRI, the one in the middle. So they had diffusion changes along the basal ganglia, patchy abnormalities out here, and also the cortical regions in the bilateral hemispheres, frontal, parietal lobes, temporal lobes. So this was discussed previously, and we raised the possibility of biotin thiamine related disorders. Hence, the child was started on biotin and thiamine. FLAIR and T2 sequences again demonstrate these abnormalities in the deep gray nuclei, the subcortical cortical regions, and also the cerebellum. The only odd point was for biotin thiamine, the involvement of the cerebellum, at least at this age. The early infantile ones can have cerebellar involvement, but usually at a later age, it's usually the deep gray nuclei and the subcortical cortical regions. Cerebellar cyst, as seen on the left side, not related to the condition, clinical presentation at least. Mitochondria also was suggested at that time, and a genetic study was done initially, which demonstrated this variance. Then a follow-up was done. Is that right, Anishma?
Yeah, in that the initial this CACNA one and NEMF, which was not fitting, but this epilepsy pyridoxine dependent autosomal recessive likely pathogenic we gave from initially he was on pyridoxine also. We gave higher dose of pyridoxine, and child is now discharged.
So child has responded. Is that right? Or...
Responded means the like after the final MRI is showing lot of cortical atrophy and vasodilation of ventricle, but there is no seizures as such now.
Okay. At least the MRI picture is not suggestive of PD. I'm not sure if anyone has any experience of the gene and the clinical and imaging aspects.
I can confirm this MRI is not in keeping with pyridoxine-dependent epilepsy. It must be perhaps something else or a dual diagnosis.
Yeah, I agree.
Okay, sir.
So I mean, completely agree that MRI changes are do not closely resemble the PD-related disorder. So I think reanalysis needs to be done, or parental analysis based on the mode of transmission, inheritance. Sorry. Yeah, I would consider an alternate diagnosis, Vishwa, based on the imaging findings at least.
No.
Can you ask him to check for mitochondria? Yeah,
That gene is very important because homozygous and deletion, there is a deletion, so that has to be pathogenic. What was the history again?
So this child
Neonatal
is a
onset
third
yesterday.
child of non-consanguineous marriage. He had neonatal onset seizures. Used to get seizures once in 3 months like that. He had mild motor delay and otherwise and speech delay. He was going to school and all. And now he presented with fever and associated day 4 he got like status epilepticus and he was referred from outside. He was intubated. He was on 4 anti-seizure medication.
So see this neonatal onset seizure, that this has to be pyridoxine dependent epilepsy, and especially if they were convulsive clonic seizures. There shouldn't be any doubt, especially with the first baby having seizure 3 months of life. Because we did have a study published recently, brain communication, where we looked at all EIDs which came to us, pyridoxine dependent presence nearly always in the first month with that convulsive seizures. Sort of, we all know that. The thing is, probably this child had secondary involvement with, some infectious illness, fever with status, which caused all these secondary MRI changes in the brain when you did the MRI. Rather, so this child has a background of pyridoxine dependent epilepsy, and often these patients, pyridoxine dependent patients, they really worsen in a febrile illness and really worsen. Even if they are on pyridoxine, their dose needs to go up. And this child probably was not on pyridoxine when the child worsened, right?
Was not on pyridoxine, sir.
Right. So this all could be just secondary changes, either the infectious process or the status. This has to be pyridoxine.
Okay.
And unfortunately, this atrophy has remained because, the secondary changes, the sequelae to the secondary changes. Infectious process plus status must have caused this.
There is cerebellar atrophy and both cerebral atrophy in the repeated MRI.
That will come because diffusion is restricted.
That will come. Yeah, that will come.
Any child, neonatal onset convulsive seizures has to be could be anything else, but especially with a SIP death. And that gene there is a deletion, so very important. So there must be frame shift mutation.
Okay, thank you, sir.
Okay. Well, thanks, Dr. Vivek. And I think, can you quickly go through the last one?
Second case. This was also we discussed. This was a 3-year-old girl. She presented with high-grade fever for 1 day with cough and vomiting. And there was left eye blinking. There was initially prolonged seizures. EEG initially was normal, improved with 2 anti-seizure medication. Within 48 hours, she had sleep disturbance, recurrence of seizures, and altered sensorium. Developed pedioral dyskinesia and dystonia of upper limb and irrelevant laughter episodes. Repeat EEG showed extreme delta brush pattern on the frontal leads in awake EEG and diffused by hemispheric slowing.
Okay, I got. I'll show the images. Okay, we discussed this previously.
We discussed this. This was
bilateral is again bilateral hemispheres. These are flares. The encephalopathy did not pick up anything other than the left cerebellar old hemicitrine deposit. And then we thought of these are the critical possibilities. We thought of MOG-related cortical encephalitis as one of the main possibilities. Again, permanent MOG or multi-MOG encephalitis can have these pictures. And then it turned out to be MOG positive.
She was MOG positive and she was on steroids and MMF also. This happened in July 2023.
Yeah. And then you just wanted to show it was on a follow-up scan after 6 months.
Yeah, follow-up scan, she improved, except there was a parietal lobe, some few.
Few residual changes are there, but there is some interval improvement in comparison to the first study. The atrophy is expected, but the lesions the antibiotic changes have improved. So we just wanted to Yeah,
She
sorry.
is off MMF and steroids now.
Okay, yeah. So we just wanted to show a follow-up scan on medication and how the changes have improved. In
Is the
comparison to
MOG
the first
negative
study.
now?
Repeat MOG is negative, sir.
Right. And in the episode, it improved with methylpred alone or methylpred IVIG? What was given in the first?
Methylpred and IVIG she was given, sir. And 2
Right.
doses of rituximab also she required.
So she had to go to the third medicine, right?
Yes, sir.
For improvement. So that's something I just wanted to again discuss because there's a 2 group of MOGs who come. There's one group of MOG, optic neuritis, responds to steroid really well. And maybe myelitis also sometimes, but then there is this bad group, this bad cortical encephalitis, and one I'm managing still, who they don't respond to methylpred and IVIG that well. And I have been now doing, and I would suggest to do CSF IL-6 levels, and if they're really high, forget about IVIGs and plasmapheresis with methylpred, give tocilizumab. And even not rituximab, because tocilizumab works in 3-4 days, rituximab takes 7 to 10 days. Well, here you are dealing with condition where every day is important. So it's just my sort of in the last 6 months, sort of what I've realized. And with CSF, IL-6 is not costly, just 1,200 rupees for us here. So we'll always do a CSF. So if IL-6 is high, normally it is less than 7. If it is something like 50, 60, and your methylpred has not worked by day 3, day 4, haven't found IVIG or plasmapheresis that helpful, you end up going to the third medicine. So better to maybe try tocilizumab instead of IVIG or plasmapheresis in this group of patients, the bad ones, because we have this very bad group as well.
Okay, sir. Thank you.
All right. Yeah, that's a last case. If there are no further comments, thank you again for the cases and the panelists for joining us with their valuable inputs. We'll meet again in 2 weeks.